Hello and welcome. I'm Jessica Keene, and today I will be talking about opioid abuse and misuse in the elderly. This is a silent epidemic that has escaped the shadows in recent years and is now bringing healthcare providers and government together to address an issue that stayed under the radar for far too long. Like the icebergs pictured in this presentation, there is so much more beneath the surface, and we've only seen the tip above the water. According to the CDC, 2014 was a record year for overdose-related deaths, and approximately 60% of those involved in opioids. The fastest growing population in the United States is the older adults aged 65 and above. They are also the most underidentified and undertreated group in regards to opioid abuse, misuse, and treatment. This presentation will address the problem of opioid abuse and misuse in the elderly, the social ecology model spheres, a suggested plan for addressing this problem, and potential resources and barriers that may influence the suggested plan. Older adults aged 65 and above are the largest consumers of prescription drugs, and this includes opioids and psychoactive medications. The baby boomer generation is entering the geriatric age range and will be more amenable to taking prescription medications. They grew up experimenting with substances and were exposed to marijuana, LSD, and other psychoactive substances. They are not as stoic and leery of drugs like their parents were, and are more likely to continue treatment with prescription medications for a long period of time. This is a large population group entering into older adulthood. By 2029, all baby boomers will be over age 65 and will make up 20% of the United States population. Older adults are living longer than ever before and are living with chronic comorbidities that are associated with non-cancer chronic pain, such as osteoarthritis. Older adults are more likely to obtain a prescription for an opioid from their provider versus younger adults, and misuse their opioid medication due to inadequate pain relief versus getting high. Severe pain and discomfort is the most common reason individuals look elsewhere for opioids. These individuals may also create unsafe combinations of medications by seeking prescriptions from multiple providers, obtaining medications from family or friends, or by stockpiling medications over time. The overall impact on healthcare is growing right alongside the number of baby boomers. This not only affects the individual, but also their families, friends, healthcare providers, and taxpayers. Emergency room visits related to opioid overdose or adverse events like sedation or falls increases healthcare costs, as does the number of individuals that will eventually need treatment. This issue matters to families, friends, healthcare providers, mental health providers, substance abuse treatment centers, pharmacists, community partners, social workers, and government agencies, because the baby boomer population is growing and utilizing more healthcare. The social ecology model offers a method of analyzing not only the physical attributes of a problem, but also the psychosocial links that it can impact behavior and affect behavior change. This model can demonstrate how people interact within their social and physical settings over time, and how this influences a certain behavior. Considering these factors and utilizing them for suggested behavior change can help ensure that the change is culturally impactful and long-lasting. By assessing the pieces of this model, we can understand and target the elements that can successfully impact change. The individual elements of the social ecology model to consider include gender, as women are more likely to misuse. An individual is more likely to abuse or misuse if they have a history or family history of substance abuse or mental health illness. Individual behaviors that may influence misuse of prescription opioids include previous criminal activity, victims of abuse, depression, severe anxiety, and insomnia. There are many comorbid illnesses that can also play a role, including chronic pain, sensory deficit, suicidal ideation, decreased range of motion and mobility, and cognitive decline. Veterans, persons of lower socioeconomic status, and education are more likely to misuse and abuse medications. An individual's perception of and tolerance to pain, aging, and treatment are also a major influence. Genetic variability may also play a role in how likely an individual is to become addicted to a medication, and also how treatment can be tailored to meet the genetic needs of a person. Social support from friends, family, and community or a lack thereof, leading to social isolation, homelessness, and stigma, are all interpersonal elements to consider. Stigma associated with drug use is difficult for anyone, but especially so for an elderly individual. It creates an environment in which an individual is afraid to reach out for help and leads to social isolation. Lack of awareness by social support systems and healthcare providers also influences prescription abuse and misuse, in that screening, identification, and treatment is delayed. Prescription opioid medications being shared among family and friends, and drug availability in the neighborhood may also influence misuse and abuse. The cultural attitudes of an individual towards medication, pain, and treatment is another strong element to consider. Stigma and ageism within the community, or believed by healthcare providers, is a major element within the organizational sphere of the social ecology model. The use of multiple providers, poorly managed pain, and the lack of training in pain management in geriatrics amongst providers are also an influence. The aging patient is likely to present to their provider for multiple problems that are to be addressed within a limited amount of appointment time, leaving little time to address opioid use. Available community resources and treatment options also affect the success of rehabilitation. The accessibility of mental and behavioral health, geriatric-centered treatment centers, and community engagement in addressing the issue are also important organizational elements to consider. Lack of awareness and acknowledgement of opioid abuse and misuse among the elderly is an element in the community sphere that can stem from the ageism and stigma associated with it, and produce poor monitoring by healthcare providers. The community's lack of awareness can be a determining factor of whether or not an issue is a public health concern within that area, and can impact the number of treatment centers available. The availability of inpatient and outpatient treatment centers and age-specific group sessions is a factor to consider when looking for potential solutions. Elderly patients may receive multiple prescriptions for the same medication, may hoard medicine, or receive medicines from their friends and family. Appropriate disposal facilities for these extra medications within the community could make an impact on the availability and accessibility of medications, and make medication management less confusing. National take-back days are available throughout the country to help reduce diversion, but the size of the community and number of participating disposal facilities are a determining factor of whether or not this is available. The ongoing training and education for patients, providers, prescribers, and citizens in the community is paramount to successful solutions in reducing prescription opioid abuse and misuse among elderly individuals. Since 2014, there has been a demanding push at both the state and federal level for opioid prescription reform. In Idaho, a House bill in 2014 was signed to allow for providers in other states to access the prescription drug monitoring program, because so many patients were being treated from neighboring states. It's also required for every provider to be registered with the prescription drug monitoring program so that it's easier to track prescriptions. House Bill 108 also passed, allowing for the prescription and possession of naloxone. Idaho allows pharmacists to independently prescribe naloxone for patients and families. At a federal level, the CDC produced guidelines for prescribing opioids for chronic, non-cancer pain to assist providers in choosing appropriate treatment options. Prescription drug monitoring programs are now in 49 states and have assisted in the decrease of doctor shopping and pill mills. The Veterans Association has also taken a stand and supports opioid overdose education and naloxone distribution to help veterans at risk. The FDA has also taken multiple steps to address this issue in the form of incentives for abuse-deterrent formulations, reformed opioid labeling, augmented safety warnings, rescheduling of hydrocodone to Schedule II, and improved access to naloxone in the form of a nasal spray. Most patients in the geriatric age range are insured by Medicare. Access to treatment centers that are reimbursed by Medicare needs to increase, which can be influenced by both state and federal legislation. The fixed income that many patients live on should not be jeopardized for treatment. Federal grants covering research for opioid-specific screening tools, education, and training of geriatric providers, and geriatric-specific opioid addiction research are also limited. The problem of prescription opioid abuse and misuse among the elderly is a multifaceted concern and is affected by many different elements. There are local, state, and national factors that play into considering solutions for this issue. There is not a one-stop, fix-it-all solution that can be made at one level without support and change at all levels. One of the most beneficial ways to affect change on a national level, and potentially global, is to set a shining example at a local level that can be expanded on. Implementing a successful gatekeeper program within the community could set a precedent for other communities across the nation. This program would train volunteer, non-healthcare members of the community, including postal workers, utility workers, neighbors, etc., in identifying elderly members of the community that may be at risk for opioid abuse or in need of social services, and referring to the appropriate social resources. This would help stimulate the engagement of the community and could also address lack of awareness and the stigma associated with opioid use in the elderly. It is a way for non-mandatory reporting individuals to see their role and the need for help in the community. This kind of program integrates well with a community aging health program, such as St. Alphonsus Center for Healthy Aging here in the Treasure Valley. This can engage community business and professionals to embrace their community and interact with it at a more personal level. The Gatekeeper program is meant to help bridge the gap between the elderly and the need for social services. It brings all the players to the table and helps initiate conversation between medical providers, mental health, social services, pharmacies, law enforcement, senior housing coordinators, and friends and families. The coalition of all the players is formed by a common thread: identifying and assisting those that may be at risk for opioid abuse or misuse. Working with pharmacists locally is of great value to providers and the patients that are affected by those providers. Pharmacists get to know their patients on a much deeper level in regards to their medications, refill habits, and trends in medications. Pharmacists also faithfully utilize the prescription drug monitoring program and can be helpful in educating other providers on how to use the program and what to look for. It is legal for pharmacists to independently prescribe naloxone in the state of Idaho. In the event that opioid misuse is suspected, pharmacists can be another provider that friends and families can reach out to in order to be prepared for an overdose situation or event. The resources and barriers identified in initiating this plan are ultimately the same. It all comes down to engagement of the community and extending awareness. Community engagement and education could be the ultimate resource, and it could also be a major barrier to overcome. A successful gatekeeper program is created by the community that embraces it. The non-medical members of the community far outnumber the medical members and are usually the first to be in a situation to identify individuals in need. Building a gatekeeper program requires working agreements with partners, establishing a lead agency, developing protocols and triage techniques, and mechanisms for sharing information. Establishing geographic boundary lines is also important, as well as state and city support. Collaboration should become second nature for providers, as working within a multidisciplinary team provides the best care for patients. Teaming up with pharmacists and utilizing their knowledge and relationship with patients is vital to identifying, assessing, and treating potential opioid misuse and abuse among the elderly. The barriers that exist are personal bias, lack of awareness, and disbelief in the issue. We also need to consider that those we are trying to help may feel targeted or like they are being watched. With the support of stakeholders like yourselves and the community, we can begin to visualize what lies beneath the surface and truly make a difference in the lives of this booming population. Thank you.